Pediatric Obstructive Sleep Apnea, OSA, is a common respiratory disorder in children that causes obstruction of the upper airway during sleep due to factors that narrow and/or increase the collapsibility of the airway. An exact cause is unknown. However, it likely involves genetic and environmental interactions in the presence of certain risk factors. OSA has a prevalence rate of up to 5% in normal children and up to 50% in obese children, with a fairly even distribution between the sexes. Traditionally, peak onset has been between the ages of 3 and 5. However, new onset during middle childhood and adolescence is becoming more common due to the rapid rise in obesity rates. OSA is a complex pathophysiological disorder that may be asymptomatic or present with varied symptoms. There is no typical sufferer in the pediatric population. However, children with one or more of the following signs and symptoms during sleep should be evaluated further. These factors can be recorded by either parental testimony or by the gold standard sleep study, polysomnography, which is usually conducted in hospitals under medical supervision. Polysomnography records brainwaves, oxygen levels in the blood, heart rate, and breathing, as well as eye and leg movements. During the day, children with OSA are likely to demonstrate additional signs and symptoms. These can result from a lack of productive sleep affecting the child's mental state, or they can be physical in nature. Increased sleepiness during the day is usually associated with adult onset OSA. However, this is also a common presentation in obese pediatric patients. It can be a vicious cycle as the daytime fatigue can limit physical exertion, which can promote additional weight gain. In contrast, children more typically present as hyperactive instead of lethargic on the account of them being overtired. These children have often been classified as failure to thrive babies. It is thought that the increased effort of respiration and the decreased sleep result in excessive energy expenditure. OSA is more prevalent in children who have adenotonsillar enlargement. This is the most significant risk factor for OSA in children, as the enlarged tissues can obstruct the upper airway. These tissues have been shown to be much larger in children with OSA than healthy controls on MRI scans. Are obese or overweight. These patients have an increased incidence of airway narrowing due to the fatty infiltrates and/or increased collapsibility of the pharynx. Have Down syndrome or certain other genetic conditions. These patients are more likely to have narrowed airways, enlarged tongue or adenotonsillar tissues, and/or decreased muscle tone. Have craniofacial abnormalities, such as a cleft palate. These structural deformities are also likely to result in decreased upper airway dimensions. Have disorders that cause muscular weakness, such as cerebral palsy. These disorders can increase the collapsibility of the upper airway. Since no absolute marker exists for OSA, diagnosis is based on clinical history and examination findings and confirmed by polysomnography. Imaging may also be taken to see if the child has enlarged adenotonsillar tissues. In children with obvious enlargement of the tonsils, no further testing may be needed, and the child may be referred to surgery to remove the enlarged soft tissue masses, which can reduce the overall obstruction to the child's breathing. OSA can go undiagnosed for years, particularly in children. Partly this is because many of the symptoms occurring at night may go unnoticed. For example, children sleeping alone are unlikely to notice snoring and also have less awareness to communicate this as a potential issue. It is for this reason that co-sleeping children are overly represented in studies, as their snoring and other nighttime symptoms are more readily detected. Differential diagnosis for OSA should also be explored with the appropriate assessments to avoid misdiagnosis, as there can be an overlapping of symptoms. The main differences include ADHD and other childhood behavioral problems, primary snoring and other sleep disorders, metabolic syndrome and type 2 diabetes, and chronic fatigue syndrome due to the potential daytime sleepiness and fatigue. Many allopathic and complementary treatment options are available for pediatric patients with OSA, including medications, surgery, dental work, sleep assistance technology, and lifestyle advice. For the best results, the specific treatment option should be considered in the context of the cause and the severity of the child's OSA. Allopathic options include surgical removal of the adenoids and tonsils. This is the first line of treatment for uncomplicated OSA, commonly due to adenotonsillar enlargement. It is important that both the adenoids and tonsils are removed to maximally increase the airway. This is often highly effective at reducing overall obstruction and restoring proper breathing. Oral appliances, such as a mouthpiece that helps to move the jaw and tongue forward to help clear the airway and make the breathing easier. Medications such as topical nasal steroids may help children with a mild form of the condition, as they help reduce swelling or mucus buildup in the nasal passage. Children suffering from allergies may use the medication known as Montelukast, which can be used to prevent wheezing and shortness of breath, or in cases combined with nasal steroids. These medications may help children to breathe more effectively through the nasal passage. The continuous positive airway pressure, or CPAP machine, helps to keep the airway open while the child sleeps. This is used for some children diagnosed with severe or persistent OSA that is unresponsive to other interventions. The bi-level positive airway pressure, or BiPAP machine, is an advancement on the CPAP machine. It has the ability to change settings and control inhalation versus exhalation, enabling sleeping patients to get more air into their lungs. Depending on the cause and the severity of a child's OSA, complementary treatment and lifestyle advice may be utilized as a less invasive first approach in the appropriate cases or in conjunction with allopathic care. These options include: if the underlying cause is childhood obesity, a suitable qualified practitioner such as a dietitian may provide advice on specific dietary changes that can reduce the child's weight to a healthy level. This may reduce symptoms in patients with current OSA and significantly reduces the risk of developing OSA in the first place. It is important that parents are advised against using food as a reward or treat and are encouraged to set a positive example of a healthy and active lifestyle for their children. Increasing physical activity, especially outdoors in nature, can help to promote brain development and healthy weight in children with OSA. Monitoring the limiting screen time is essential to promote outside play and physical activity. Various primary and allied health practitioners can provide specific advice for parents in regards to the appropriate physical activities based on each child's specific case. For a subset of OSA patients with abnormal skull development, cranial manipulation is a very gentle technique performed by certified practitioners such as chiropractors or osteopaths. This technique has been shown to improve skull shape in applicable children by naturally reshaping and promoting normal growth. Although most cases of OSA resolve during childhood with appropriate treatment, the low-grade chronic inflammation with free radical damage that occurs with OSA can have ongoing consequences. Most research in the potential complications of OSA has centered on the following. Cardiovascular outcomes for OSA show there is an association between OSA and high blood pressure during sleep. OSA affects both systolic and diastolic blood pressure. Structural changes on endocardiography demonstrate increased left and right heart wall thickening. Although the long-term complications of high blood pressure and heart wall thickening in childhood OSA is not widely known, there are other childhood conditions associated with high blood pressure that have been shown to increase the risk of lifelong hypertension. Several studies have also concluded that OSA can have an effect on blood flow to the brain, brain oxygen levels, and autonomic nervous system regulation. Pulmonary hypertension is a severe cardiovascular complication of OSA, which can result in cor pulmonale when untreated. This is uncommon in children, but it can be a long-term consequence of unresolved OSA. Neurocognitive and behavioral outcomes of OSA have shown, in 61 studies investigating the effects of OSA on brain function, hyperactivity is the most common reported symptom overall. Snoring during sleep has been shown to predict a future diagnosis of attention deficit disorder, ADD. Other behavioral and cognitive problems were also found in children with OSA who appeared to have injury to neurons within the brain and impaired blood flow to the brain on imaging. For children with key signs and symptoms of OSA, a prompt diagnosis and accurate identification of causation factors will allow for targeted treatment and the best outcomes. In most uncomplicated cases of OSA, there will be effective treatment options such as endotonsillar removal that will completely resolve the condition in childhood. For some children with certain underlying genetic and structural conditions, finding effective treatment can be more challenging and there is a greater risk of ongoing complications. However, research advancements continue to offer new medical technologies and treatment options that provide hope for the wide range of OSA sufferers.